First, I would like to say thank you to Mr. Salman and Dr. Naved and our international guest about his presentation about saliva diagnostic. Currently, in my university, Dow University, two of my PhD students, they are doing on saliva diagnostic for oral cancer patients. Today, my topic is about the oral cancer. Is very interesting topic. Like the cancer is very increasing in Pakistan, especially in Karachi, and most of the pupils they are young pupils. They have a cancer diseases. Oral cancer is a health rising concern in Sindh, especially in Sindh, even in not only in the Sindh, in Pakistan also. The oral cancer is the second most common cancer in Karachi. The most common risk factors like the betel nut, gutka, pan, niswar, even they have more risk factors, but the most common risk factors are gutka, pan, niswar. According to the cancer registry, like we have a cancer registry in Pakistan, like in Karachi, we have only two places they have a cancer registry. Like one is a Dow University, another is a Aga Khan University of Health Sciences. Oral cancer is the second most tumor in the tumors, and like the adult patients are the most common. The age is above 20 years, especially this cancer is the buccal mucosa is the most common sites, and the tongue and involved in the alveolar region. Most probably present in the advanced stages, like mortality rate is more higher in the advanced stages. Management of oral cancer. Like management of oral cancer is number one, we have options of always remove the tumor with the safe margins, like wide local excision, neck dissections, like neck dissection. If the tumor have a metastasis, like we go for the selective neck dissection, modified radical neck dissections, and then the tumors, for example, after removal of the tumor, there is some nodes positives and margins are close or involved. We will send for the CCRT, that means concurrent chemoradiotherapy. Another techniques now recently in the other countries, they are more popular, like they are doing new adjuvant chemotherapy. It means like the patient who come here in advanced stages, the tumor size is very big, then we will refer for this patient to oncologist to shrink the tumor, then we go for the later we go for the surgery to easily remove the tumor with the safe margin. Like after we remove the tumor, we have multiple reconstructions options. Like if the tumor size is small, like we will go for the healing, secondary healings, we will just remove the tumor, we don't do anything. Then another option is the primary closure. If the tumor can be after remove, we will go for primary closure. Other than like we have a superficial tumor, we will go for the skin graft. Then another, like we have advanced tumors, we will go local flap, regional flaps, and free flaps. Like here, I am presenting cases we deal in the Dow Dental College in between from 2021 to 25, and in which I can discuss and share the knowledge of the surgicals and reconstruction techniques analyzed. Like oral cancer patient treated from 21 to 25, like we deal around 92 cases in 5 years. Mostly we in 5 years we deal 92 cases in Dow University of Health Sciences affiliated with Civil Hospital and Trauma Center. Like in my 92 cases, mostly the patient present here is like the 60, the age is above like 20 years, like mostly the 65%, and the female is present in 35%. The age distribution in between my case in 92 cases, like the most common patients present in T3 and T4 cases, like, and the tumor size, like the age is small, like less than 20 or around 30. The patients, we see around 5 patients. The site distributions, like in my cases, the most common site is buccal mucosa, Another is the mandibular region and the CA on the tongue sides. The tumor we deal on this patient, like the 92 cases, mostly the patient who came here around advanced stages T3 and T4, and the T1 and 2 is the tumor size is small, the present here. Today I am presenting my first case about the buccal with the patient. She has a cancer in the buccal mucosa. Her age is around 43 years old. She is biopsy proven SCC. What we do the wide local excision and reconstruction with submental flap and neck dissection. Here we can, after removal of the tumor, they have multiple choices. Either some dentists, they do the maxillofacial, they do the nasolabial flap, but I prefer to use a submental flap. This is the patient. He has on buccal mucosa, have the SCC. Then we do the wide local excision, and we mark the submental flap, and along with the submental flap, I do the neck dissection with the submental flap. Now, on harvesting submental flap, neck dissection is little difficult to to remove the lymph nodes. Here, after reconstruct the submental flap, we make the tunnel from the mandible and place on the buccal mucosa, on the buccal sides, and this is the last picture showing the post-op picture of the 10 days later. If we use the buccal flap it's post-operatively, the patient mouth opening is better. If we cannot do any reconstruction, then there is a secondary healing that patient has a limited mouth opening. Case 2 is a 37 years old male patient, biopsy proven SCC on buccal mucosa and the skin is also involved in extraoral lesion. This case is biopsy proven, and the TNM staging is T4 and not M0. What we do, we remove the tumor with the safe margins, wide local excision, and marginal mandibulectomy. After we remove the tumor, we do the neck dissection, and we reconstruct with the tumor on the defect side with the packed major flap. This is a flap we can harvest easily in Dow University of Health Sciences. We don't need any plastic surgeon. We are doing all these things frequently in the civil hospital and trauma center. This is the post-op picture of my patient after 2 years later, after chemo, radios all done, and now he is happy in his life. Another case, the 37 years old patient, he has a tumor on maxilla and mandibles. Mandible, what we do the wide local excision, and we do the hemimaxillectomy because the tumor is involved in the maxilla and also involved with the buccal sides and also involved in the mandible. What we do the hemimaxillectomy, hemimandibulectomy, selective neck dissection, and reconstruction with packed major flap. This is the clinical picture of before surgery. We get the same marking of the patient with the same margins. What we do the hemimaxillectomy and hemimandibulectomy. Then after resection of the tumor, we plan to do the ALT flap, anterior lateral thigh flap, with the plastic surgeons. But after we harvest the ALT flap and we placed on the defect sides, few weeks later the flap gets necrosed. So after necrosis of that flap, we remove the flap and we put the patient on the only dressing. Then dressing once the patient get infection free, then we use the packed major flap for reconstruction of that defect. Another case, the patient has a 60 years old male patient. He has a biopsy proven SCC on lower lip. What we do the wide local excision and bilateral neck dissection and reconstruction. This is we get the same margins and we remove the wide local excision. Mostly two-thirds of the lip we remove. We do the bilateral neck dissection and we place supraclavicular flap for reconstruction of this lower lip defect. Another case, the female 55 years old female patient, Like she is a biopsy proven SCC. What we do the wide local excision and neck dissection and reconstruction with parapenzetic flap. Parapenzetic flap we use for the reconstruct with this defect. This is the post-op picture of the patient with the closed mouth and open mouth. And another case is the female patient. She has a biopsy proven SCC on the lower mandible, like alveolar region, and what we do the wide local excision, segmental wide local excision and selective neck dissections, and we remove the tumor with the safe margins. And we harvest the pectoralis major flap for reconstruction of inner defect with pec major flap. Another case is the biopsy proven SCC on the maxilla. What we do the maxillary region, what we do the wide local excision and hemimaxillectomy and reconstruction. This is a clinical picture of the patient, like he has a biopsy proven SCC. What we do Weber-Ferguson incision and place the supraclavicular flap to cover the defect. And another case is like the 37 years old female patient. She has a SCC biopsy proven on the tongue sides. And what we do the partial glossectomy, selective neck dissection, and primary closure. On the tongue reconstruction, we have a multiple options. We do the primary closure, we do the like a skin graft, we do the free flaps, and then. But the patient, her age is 37 years old. She has a 6 months baby. So if we do the radial forearm flap or other flip flaps, she need to stay in hospital more than 7 days or 10 days. So we just do the remove the tumor with the same margins, and we do the primary closure. This is the defect size, and we remove the tumor with the safe margins. And we do the neck dissection from level 1 to level 5 with the same margins. And this is the post-op picture, like the patient after remove the tumor, and we do the primary closure. Another case has a patient has a 46 years old male patient, SCC biopsy proven on lateral tongue. Like what we do the hemiglossectomy, selective neck dissection, and reconstruction with radial forearm flap. This is radial forearm flap done by plastic surgeon, not by me. I only do the pec major flaps, some mental flaps, and other local and regional flaps. But for plastic surgery, we do the like with them for the free flap surgeries. This is the tumor. We make the tunnels and remove the tumor with the lymph nodes. And we do the radial forearm flap for the reconstruction of the tongue. Another case this is the 58 years old patient. She has a basal cell carcinoma, biopsy proven on the left side of the face, orbital region and zygomatic region. But unfortunately, she already lost her vision from that side. What we do wide local excision, eye accentrations, and reconstruction with ALT flap. Like this is the case. What we do the wide local excision, eye accentrations, and then we reconstruct with the ALT flap. Another case 69 years old patient, we have a 69-year-old patient also biopsy proven as basal cell carcinoma. We do wide local excision, advancement flap, and we cover with the small defect with the skin graft. Out of my 92 cases, mortality cases of my patients, on the 10 cases has a mortality rate. Follow-up still we are doing on 65 cases. Loss of follow-up between 17 cases we lost the follow-up. Conclusion: oral cancer in Karachi remains a growing health burden. Early detections through surgical planning are essential. Microvascular reconstructions improve the quality of life of the patients. Public awareness and training must expand. There is a take-home message early detections is the key. Regular oral examination, awareness of signs and symptoms save the lives. Any suspicious lesions, do incisional biopsy. Sometimes we do the saliva as we use saliva diagnostic, but most gold standard is in biopsy. I think the saliva diagnostic tool will take little more time. A biopsy can take around 10 days. We get the report like if the patient has a SCC or poorly more differentiated, then we plan for the surgery. If my message is for the dentist, like if you see any patient who has a lesion or anything, just refer to the oral maxillofacial surgeon or refer to us in the Dow University of Health Science. We are doing all these surgery free of cost. Even like free flaps, packed major flaps, reconstruction, we are almost doing three cases in a week for oral cancer patients. So every dentist, like if they have a patient about any lesions they have seen, kindly refer to the maxillofacial surgeon. Thank you.